My name is Dr. Petronella Adumalko. I am an infectious disease doctor working at McKay Hospital, and I'm the president of the Society for the year 2020. Our guests for today are Dr. Jason Rupp and Dr. Jessie Swift. They are both ophthalmologists at the Country Hills Eye Center, and the topic for today is ophthalmology and stem cells. So let's start off with a bio on both physicians. Let me start off with Dr. Rupp. He grew up in Taylorsville, went to Taylorsville High School, got his Bachelor in Science in Math from Westminster College, and went to Indiana University, where he did a combined MD, PhD degree. His graduate work was in the Department of Genetics, and he worked with the Huntington disease, trying to identify early biomarkers that could be used to follow disease progression. He did his residency and glaucoma fellowship at the Washington University in St. Louis, Missouri, and worked in private practice in Salt Lake City before coming to Country Hills Eye Center. Now, Dr. Jessie Swift was also born in Ogden, Utah, went to Bonneville High School. He received his associate's degree from Weber State University and Bachelor's of Science in Exercise Sport Science from the University of Utah. He then did a pre-doctoral fellowship at the Schepens Eye Research Institute in Boston for a year, got his medical degree from the Virginia Commonwealth University, and then did an internship in Tucson Hospital Medical Education, then did his ophthalmology residency at the Jones Eye Center at the University of Arkansas. He was in private practice in Albuquerque, New Mexico for about 3.5 years before moving to Country Hills Eye Center in June of this year. Welcome, gentlemen.
Thank you.
Thank you.
So before we delve into the topic, is there anything else you'd like to add to your bios? I'll go with Dr. Rupp.
No, that was pretty good.
Oh, no social activities, no hobbies, nothing like that?
I spend most of my time coaching 13, 14-year-old baseball.
Oh, okay. Well, good. No hiking then. How about you, Dr. Swift?
I very much enjoy soccer and skiing, although I haven't been able to do them as much, but I did buy my pass to Snow Basin as soon as I got back.
Okay, well, welcome back then. Before we delve into the topic, I just have a question. Is it recommended to get an annual eye exam? And if so, what age do you start from? And are there certain medical conditions or therapy that would require you to get these exams? So let's start off with Dr. Swift.
You know, I think an annual exam, at least starting from the age of around 55, is probably a good idea. There's just things that kind of start to develop as we age, whether it be cataracts, whether it be glaucoma or macular degeneration, and these sorts of things. When you're younger, as long as there's no real eye problems like amblyopia or anything like that, and the vision's very good, or if you don't have glasses, I don't think you necessarily need every year. But if you're someone who wears contacts or glasses, it may be prudent to have a yearly exam.
Anything to add to that, Dr. Rupp?
No, I think that's pretty accurate. I think the younger group every couple of years is probably sufficient without any known disease. But over 55 is a good idea to be seen once a year.
So what are some of the conditions that require the regular eye exam or regular ophthalmological visits?
So in my practice, the most common thing I see is glaucoma, as a fellowship-trained physician. So glaucoma is tough because it's not something people come in knowing that they have. They don't have symptoms, pain, vision loss. So it's something that really does require a routine exam, screening exams. Once it's identified, we typically see patients with glaucoma about every 4 to 6 months to make sure that they're not having any changes, that therapy doesn't need to be changed or increased.
How do you treat it then? Actually, what is glaucoma?
Yeah, so glaucoma is an optic neuropathy that we don't really understand the details of completely. Quite common, especially with age. As people get into their 60s, 70s, and 80s, the prevalence of the disease gets into the double digits. So very, very common. It's associated with high pressure in the eyes, the only modifiable risk factor for it. And so all the treatment is targeted towards lowering intraocular pressure. We do that initially with laser treatments and drops, and then as needed, move towards surgery. It's not a curable disease, but the treatments we have are pretty good. The hardest part is finding it early. When we see patients who come in with very, very profound vision loss, 80 to 90% of their peripheral vision gone, then the stakes get higher. The disease typically advances more aggressively, and it's harder to treat.
It's not reversible then?
It's not reversible, no.
I see. So what does surgery entail for glaucoma?
We're just fancy plumbers, basically. So the goal is to increase outflow. So aqueous humor outflow through various methods. There's a new sort of push in glaucoma over the last 5 to 10 years to increase the use of the normal physiologic outflow pathways through stents, through removing tissue. Traditionally, though, glaucoma surgery has been creating new outflow pathways, either by, it's called a trabeculectomy, which is essentially making a hole in the white part of the eye and creating an external reservoir, or through a tube shunt, which is a mechanical device that drains the fluid from inside the eye back to the equator of the globe, again to an external reservoir.
How does the laser therapy work?
We don't know completely, though there's some pretty good evidence over the last several years to tell us that it's an increase in macrophage activity in the trabecular meshwork of the eye. So most of the resistance to outflow of fluid happens at what's called the trabecular meshwork. Explain to patients that it's basically like a mesh cap that you have over the drain in your bathroom sink that with time is going to get plugged up. Those macrophages, the light energy from the laser stimulate more activity out of the macrophages to clean up the debris, essentially. Older versions of it blasted holes through it, but the newer lasers don't do that. Even with electron microscopy, there's no identifiable tissue damage, so it's all stimulation of the natural cells there.
That's interesting. Thank you. Our topic for today is ophthalmology and stem cells. So, any role for stem cells in the treatment of glaucoma?
Unfortunately, not yet. I think it's a great potential. As a neuropathy, regrowing nerve cells is a difficult thing. Regrowing them to connect directly to the brain and through the pathways to the occipital cortex is a significant challenge. Hopefully, we get there. The diseases that will be treated first in eye disease with stem cells, glaucoma is probably not at the top of the list because of those challenges of regrowth through such an extensive pathway. Jesse, I think, knows more and can speak more to retinal diseases, which are probably, at least initially, more prime targets for stem cell therapy in eye disease because it's more generating new growth and neuronal tissue in a more local environment is probably a more feasible goal initially.
Okay, thank you, Dr. Rupp. So, Dr. Swift, any other chronic eye conditions that need regular follow-up?
There are many, but I guess in my world, I see more with the retinal issues, in particular macular degeneration. It's one of the most common forms of blindness in the United States. There's different versions of macular degeneration. There's wet and there's dry. And so what's going on in macular degeneration is there's 7 layers to the retina. There's the nerve tissue, the ganglion cells, there's photoreceptors, amacrine cells, horizontal cells, and then there's a little layer called the retinal pigment epithelium, which is interestingly enough, towards the white part, towards the sclera. And what they do is they absorb UV light, and they also get rid of waste materials that form from the photoreceptors, which are very heavy on energy use because they're the ones that take the light and change it into electronic signals that then send back to your brain. And so in macular degeneration, it's that pigment layer that dies off. And we've looked into a lot of different things, and there seems to be a genetic component to it, but why that gene kind of breaks down at a later age is not exactly understood. But in essence, that layer dies off, and when it does, the waste material builds up, and then those photoreceptors that are above that sick pigmented area, they die too.
So aside from the probable genetic component, are there any possible or probable risk factors that lead to it?
Yeah, it tends to run in more Northern European descent with light eyes. Those are, the probably the biggest risk factors, and age is also another big risk factor for macular degeneration.
What are the signs?
Gradual decrease in vision. A lot of people kind of note that their vision just isn't as sharp. Um, Night vision becomes more difficult. Faces become more unrecognizable. Colors are kind of decreased.
I see. So since we really don't know the risk factors are not clear cut. So the screening, or would you say screening is recommended starting from the age of 55 for everyone?
Yeah, yeah. I mean, especially if you have a family history of macular degeneration, you probably would want to start kind of being seen maybe a little earlier. But yeah, I think 55 is definitely reasonable. I'll admit, most patients with macular degeneration are typically older, I'd say 70s and above, but there are definitely a lot of people in their 60s who have more aggressive forms of it.
So what do you see on exam when you see these individuals?
You see it on the dilated exam in the what they call the fundus. So you look in the back of the eye, and oftentimes you'll see these little spots called drusen, which is that waste material that we just briefly mentioned before. Those are what those drusen deposits are, and they're just underneath the retina. They're kind of a whitish yellow color. They can be what they call hard or soft drusen, depending on the size of it and what their appearance looks like. You can also get clumping of that pigment layer that has little areas that they kind of clump. There's also what they call RPE atrophy, which is basically that pigment layer is just gone, and it's just you can almost see through it, and it's just a different color altogether.
You did say wet and dry. Just curious, what's the difference?
So dry just means that there is pigment changes that you can see with the drusen deposits and whatnot. But wet macular degeneration, what's going on there is, so underneath the retinal pigment epithelial layer, there's an area called the choroid. It's very vascular, and this is where there's a lot of blood vessels and a lot of metabolic exchange, I guess you can say. And those blood vessels are kept at bay by the pigment epithelial layer. But when that barrier decreases, the blood vessels will actually grow underneath the retina, and they can bleed, they can leak. And when that occurs, you get swelling underneath the retina, and that's what causes a kind of more of an acute change in people's vision. And so typically, people who have more advanced dry changes are more at risk of having to going into wet. And so we actually give them this little grid paper that seriously looks just like grid paper, and they're supposed to look at it, ideally every day with each individual eye. And what they'll notice is distortion on that grid paper. It would be very different from one day to the next potentially, and that's kind of an early detection to come on in and see what's going on.
I see. Thank you. So what's the treatment?
So with dry, there actually isn't much treatment. There's actually eye vitamins. It's called the AREDS2, and it's just a concoction of vitamins, most of which are kind of to get rid of free radicals is kind of the thought process. And what they did was they studied over years these vitamins, and they found that people with moderate to severe macular degeneration, it slowed it down. It didn't stop the process, but it did slow it down. I think it's reasonable in people with early stages of macular degeneration to start the vitamins as well. And some people have even done it if people have a family history to go ahead and start them, although there's really no data to suggest that will help keep the onset of macular degeneration from coming on.
What are the names of the vitamins again? AREDS2, you said?
That's correct.
So is it like what, vitamin A in there? Is there vitamin D in there?
There's zinc, copper, lutein, zeaxanthin. So they used to have beta carotene, which is kind of a derivative of vitamin A, but that was with the AREDS 1 formula. But as it turns out, what they found over long-term data is that former smokers with beta-carotene were more at risk of developing lung cancer.
And that was a treatment for the dry.
Correct.
Right. So what about the wet?
So the wet version, we actually do have medications, and the mainstay is really what they call anti-VEGF. So so the VEGF stands for vascular endothelial growth factor, and so
I like your acronyms.
yeah,
Yeah, we're full of those.
yeah, we have a lot of them. So essentially what these factors do is it stabilizes the blood vessels, essentially is what happens. So we inject them into the eye, into the vitreous, which is behind the lens. So if you think of the eye, it's kind of like a basketball, right? The front part's got the cornea, and then there's a space between the cornea and the the iris is that, blue or brown part. Behind there is the lens. And then behind the lens is this big area where it's just filled with jelly called vitreous. And then behind the vitreous is where the retina stands, and then the choroid, and then the sclera is the white part that surrounds the entire eye. So we're injecting these medications into the vitreous.
Okay. The last question on that. What role does stem cell therapy have in macular degeneration?
That is a good question. So I guess at this point in time, they do have some phase trials. I think they're on stage 2. But right now, for the average person, there is no stem cell treatment. Now, they have been looking at this for quite some time. And actually, that was part of what I did in before medical school is I was doing stem cell research at Scapins. It's exciting because the whole thing is maybe we can regrow a retina. We can regrow all the layers that are damaged or dead or gone, and maybe regain some function. So I think that's where the role of stem cells kind of plays an interesting part in terms of the retina. As it turns out, the retina is pretty complex. And it's harder than you might think to regrow all those 7 layers and have all the good connections going back to your brain. So, what they have done so far is they've done a lot of mouse models, and they've been able to essentially grow the different layers of the retina, the pigment epithelial layer, the photoreceptors, using embryonic stem cells, and also what they call induced pluripotent stem cells. So what that means is embryonic is where the sperm and the egg meet together, and there's actually different layers to it, and they can take some of those cells, and those cells can become any cells in the body. And so you can give them growth factors to turn them into whatever it is that you want. And so they've been able to do that with the eye tissue. What induced pluripotent stem cells is actually, taking an area that has stem cells like your bone marrow or fibroblasts from your skin, and then basically giving them a certain concoction to reverse that, to basically turn them back into more of a totipotent state where they can then change them into not whatever they want, but to some degree different tissues. And they've actually been able to take these induced pluripotent stem cells and actually make retinal tissue from it. And that's actually where 2 of the studies that I've kind of read about where they've been able to take from. And essentially what they did on both of them was so for the embryonic stem cells, they basically took these cells and differentiated them into retinal pigment epithelial cells. And then they reintroduced them back into the eye. And they were able to actually grow some areas, or at least have some pigment areas that were new on some people. And there's different ways of they have been doing that. So one is they would just do intravitreal injections, just like we do with anti-VEGF. As it turns out, you kind of need to direct cells. You can't just inject them. They're not exactly, they're not just going to go where they need to go and change into where they need to change. But they did have some interesting data just from doing that. The other way that they've done it is they've actually done retina surgery. They remove all the vitreous, and then they do an injection underneath the retina while in the operating room with some stem cells. And you can imagine there's possible complications from that, but they've also been able to kind of grow some have some interesting findings with that. Probably the more interesting thing that I saw is they took these induced stem cells and then they reversed them, and then they made retinal pigment epithelial cells, but they put them on a scaffolding. It was some sort of collagen. I think it was a type 1 collagen. So they grew these cells, they put them on the collagen, they took the collagen, gave it to the surgeon, he removed all the vitreous, made an incision through the retina, slid this scaffolding system into the area of atrophy with this pigment cells that they've grown, and they actually showed that it actually survived. Like they had a new layer of retinal pigment epithelial cells. Now their vision really wasn't much different because they had already lost the photoreceptors, but that does show that, hey, we can actually grow some things and put it in the body, and they can actually survive, which is pretty interesting.
Wow, and this is in humans, right?
Yes, that was in humans. It was about 5 eyes, so not a lot of eyes, but still very interesting.
Okay, well, it is certainly interesting. Okay, cataracts. We have to talk about cataracts. Dr. Rupp,
Yes.
can you tell us about cataracts, please?
Yeah, so cataracts are usually the time when I get to tell patients in the office that they're getting older, which is never fun. Now, so cataracts are an aging process of the lens in the eye. My experience is that by about the age of 50, almost everybody has the earliest signs of those, which is a color change. The lens goes from being clear to becoming a little bit of a yellow, having a little bit of a yellow tint. It's typically not symptomatic for the patient for many years, but eventually that yellowness becomes darker, it becomes cloudy, and it's like looking through a dirty window all the time. So patients eventually will start to complain that their vision's decreased. 3 of the more common things I hear from patients are difficulty driving at night. Glare from headlights is a common symptom and can be very, very problematic for functioning. Difficulty reading in dim lights happens to everybody slowly, but eventually can become really problematic. And then people who they say, I've updated my glasses. I keep trying to get new ones. They've remade them, 2 or 3 times. I just can't see as clearly as I used to. What's going on? And those are kind of the 3 most common complaints. People will have all sorts of very specific things about what they can't do with their vision that they used to be able to. Cataracts are, at this point, treated surgically. We go in, we remove the entire lens out of the eye, and then we put in a lens implant, an acrylic, typically, sometimes a silicone lens, into the eye that stays there and does not need to be removed in the future. So it's a one-time curative treatment for most patients.
Any role for stem cells?
Probably not. There are some medications that are being tried to reverse the effects, the aging effects, to try to roll back the clock a little bit. So not exactly stem cells, but in a similar vein. The other thing that happens kind of in parallel with cataract formation is the need for reading glasses, or what we call presbyopia. So the lens in the eye changes shape as we try to focus on things up close. And with age and the yellowing of the fibers there's also a stiffening, and those kind of go hand in hand at about the same time. There are some medications that have been, there's a treatment that's been used in South America, and this has started to gain a little bit of notoriety and being looked at a little bit more closely to reverse the effects and prevent the effects of presbyopia. Time will tell if that is able to slow down cataract formation as well. I've had a few patients one in particular who's told me that he's waiting for medications to reverse his cataracts. I've told him he's probably going to wait a while. I don't think it's completely unrealistic that it may come at some point. For now, though, it's kind of way out on the horizon.
So it's nothing that one can prevent. It just comes with age.
It just comes with age. There's some role of UV light exposure. People who spend a lot of time on the water or the snow may develop cataracts faster. We talk to patients frequently about wearing UV protective sunglasses. Maybe that slows down cataracts. It may also have some preventive effects for macular degeneration. I think that the preventive effects for cataracts in UV sunglasses is probably pretty minimal, except for people who are in very high UV exposed areas. Pilots would probably be another one of those groups.
I guess Dr. Swift can ski with no problems then, right? He knows the necessary precautions to take.
That's right.
So what other medical conditions do we need to worry about in general with that come with eye complications? I know there's diabetes. What do we need to worry about with diabetes, high blood pressure?
Diabetes is probably the most common thing. Diabetic patients, we recommend that they have an eye exam once a year or more if there are signs of retinopathy associated with that. The internists out there probably know much more than we do. That people live with diabetes probably for some time before they're typically diagnosed. And so type 2 diabetics, we recommend that they have an eye exam at the time of diagnosis. Their blood sugars can frequently be quite high. And retinopathy, risk factors for retinopathy include not only the length of time that a person's had diabetes, but also the extent of their blood sugar elevations. So with diabetic retinopathy, we generally early on, we see microaneurysms in the small vessels of the retina. We see some small intraretinal hemorrhages. As it progresses, we can start to see edema, we can start to see new blood vessel formation and even traction in the retina that can lead to very serious problems. The treatments early on are typically the same things that they're hearing from their internist. Blood sugar control, blood pressure control, get the disease under control with medication and lifestyle changes. As the disease progresses, we use the same anti-VEGF medications that Dr. Swift talked about. We use laser treatments, eventually, occasionally surgery. It's very difficult, though, to see, particularly young patients with very, very advanced diabetic retinopathy, knowing that the course is not typically a good one. Some of the early changes are reversible. Once it progresses to the what we call the proliferative phase, meaning new blood vessel formation, traction in the retina, extensive areas of bleeding, generally it's not reversible. At that point, it becomes, can we try to manage this? One of the things that comes later is not only neovascularization in the retina, but also in the front part of the eye. That's where I typically get involved, is those new blood vessels actually grow over the drain, the internal drain, and patients develop very, very severe painful glaucoma. And so we try to lower their pressure by getting around that neovascularization. But those are eyes that typically will see very, very poorly at best for the rest of their lives.
So infectious disease, I cannot go away without talking about an infection. So Dr. Swift, what infections do you see? What interesting infections, common infections?
Sure. Probably the most common that we see in the office is, around the eye and in the eye. Around the eye, abscesses in the eyelids and things. You can get the meibomian glands, which are the oil glands around the eyelashes. They're part of the tear film, and they're supposed to be there, but sometimes they're like toothpaste, and they get backed up. And when that occurs, you can get infections, which we call styes. Most of the time, styes aren't a problem. You can do warm compresses and help them go away. But sometimes you got to make an incision in drainage, and sometimes you got to put them on oral antibiotics. There's also conjunctivitis, which I'm sure everyone has heard about. Most of the time, conjunctivitis is viral, but it can be bacterial, and there are some serious bacterial conjunctivitis. I don't know how to say that plural, but conjunctivitis.
That's it.
One is potentially, gonococcal. That happens more in kids, and, or usually within the first week of delivery, a vaginal delivery. But, those can be very serious infections because that bacteria can actually go through the cornea. Not all bacteria can, but that one can. After cataract surgery, like we kind of had mentioned, there's risks and benefits to anything that you do, surgery in particular. You can always get an infection after surgery. Endophthalmitis is an infection inside the eye. Typically, they're gram positive, but they can be gram negative, and those can be very serious infections where loss of vision is not uncommon. That's sort of a double negative, and I'm sorry about that. But yeah, that certainly can happen after cataract surgery. Usually thus treated with intravitreal, just like we talked about before, inside the eye with antibiotics and sometimes steroids too, because the inflammation can be just as bad as the infection on the eye as well. So let's see here. Where else can we get infections? Man, those are probably the big three.
Yeah, I would add into that herpes viruses are a big problem with the eye. We frequently have patients referred for shingles. People who have shingles and a V1 or V2 distribution on their face are at high risk for ocular involvement, either on the cornea, the surface of the eye, or as an intraocular infection / inflammatory process. HSV also causes ocular disease, and is probably, I see it some. It's probably, speaking for our cornea specialists, it's probably the bane of their existence, because it can be so difficult to treat. Recurrences are very common. It can go very, very rapidly, and it can cause some pretty severe permanent scarring that can really impair vision. Some of those patients actually require corneal transplants, depending on the location and the extent of the scarring. But in addition to what Dr. Swift said, herpes viruses can be very challenging in eye disease.
Thank you. So a few last questions. When would you recommend primary care providers refer patients to you? What are considered emergencies?
When I go and talk to primary care docs, I say, I've been in enough primary care offices as a medical student and in training to know that when an eye problem comes in, I think the thing they want most is for it to be out of their office. and so feel free to call and send it along. Identifying emergencies is obviously a different ballgame. Things that have produced significant vision loss. And you don't have to have a Snellen chart. You don't have to say, are they 20/20, 20/40? See if they can read. If you're in a hospital and you have a name badge, can they read the big letters on your name? Can they read the smaller print on the backside? That at least should give kind of a ballpark of the extent of their problem. Pain is also a pretty good indicator. There are things that are benign, like a viral conjunctivitis, that can cause pain, but people who have severe pain, ocular pain, light sensitivity, generally warrant being seen within a fairly short period of time.
Great, thank you. Dr. Swift, anything else to add?
You've been asking about kind of things that we should watch for. I know you probably don't really ever prescribe Plaquenil very often, but Plaquenil is one of those things that has a dose response where it can cause problems in the macula. It can cause what they call bullseye maculopathy, where that does kind of destroy the pigment epithelium in a bullseye fashion. Typically, that's over many. Oftentimes it's after 5 years, but we do need to get baseline stuff, and it's good to watch those people because the damage can still continue even after stopping the Plaquenil. So it's good to figure that out if they're starting to have it, to stop it immediately. The other thing is this one might pertain to you more as an infectious disease doctor. Ethambutol can cause optic neuropathies. And so if they're started on it, they're seen fairly frequently, about every month, at least that's the way I kind of had done it in the past. And maybe Jason does it a little bit different, but about every month I'll check on them to make sure there's no optic neuropathy with visual fields, what they call an OCT of the nerve, and color vision. And if they start kind of having those changes, that needs to be stopped if they can. As soon as they can.
Are those changes reversible?
They are not. Yeah, none of those changes are reversible with Plaquenil or with ethambutol. There's another one called Elmaron, It's a bladder medication it's an interstitial bladder medication that has been around a long time. It's really the only medication out there, but it can also cause changes that look like almost like macular degeneration, or what they call pattern dystrophy in the macula. And so again, it's an irreversible effect. So finding these things early on is a good thing, so we can stop them.
Okay. And finally, clearly we have this, we're doing this because of the pandemic. So what role has COVID-19, what impact has it had on your practices? Do you see any cases?
Personally, I have not, but there have been, like, for example, the guy in China, the whistleblower, he was an ophthalmologist, and he was finding out a lot of people were coming in with conjunctivitis and having these breathing problems. He actually ultimately died from COVID-19. But I can't say that I've seen COVID-19, but people that do come in with, conjunctivitis, a lot of times I'll tell them they should probably go get checked.
Okay. That's right.
Early on, back in February, March, a frequent visit for us is a pink eye, red eye type visit. And initially we turned to telemedicine for all of those to try to triage those, because it can be a symptom of COVID. I think as we've seen, we've gathered a little bit more data, we've seen kind of what normal presentations look like. The conjunctivitis part of this is I think less prominent than other symptoms. And so people, we have pulled away from that, and we're just pretty much having those patients come in at this point. There is still some evidence that it can be spread through tears. There's evidence that it can be spread, you can become infected as an exposure through the eyes. So certainly precautions are warranted with our equipment and the proximity that we sit with people at the microscope. We've put up physical barriers and things like that. But I think our role is a bit more limited than maybe we thought it could be in the beginning, as we were hearing about the conjunctivitis associated with COVID. I have not seen any. Our practice has been diligent in screening for patients, but also lucky that we haven't had any big problems at this point.
Great. So anything you both would like to say in conclusion?
Eyes are important.
Window to the soul? Is that what
right. Yeah, I've heard that.
Dr. Rupp, what about you?
Kind of along those lines, people have surveys done of what senses people want to lose. Vision is at the very bottom of that list. And we hear that all the time in our practice. People say, I could deal without this or this or this, but I can't lose my vision. It's also a very unique part of medicine that we don't cross over a lot in terms of our types of exams that we do. So if people have questions, if there's concerns, if you're just not sure, we're happy to help. And we'll reach out to you when we're hearing other things, because we don't feel very comfortable anywhere else.
Well, Dr. Rupp, Dr. Swift, thank you so much. They work at County Hills Eye Center. The phone number is 801-399-1149 if you need to call them.
Thank you very much.
Thank you.
Bye now.
The producers for this podcast are Clark Madsen, MD, MS, Teresa Puskedra, MPC, and the OSMS Board of Directors. The Executive Director is Teresa Puskedra, MPC. The host for this podcast was Petronella Adamaco, MD. Editing and sound design was by Colton Gomez, supported by OSMS members.